It's a very good question. So it's a disease that is aggressive. It doesn't respond very well to chemotherapy. And so it's usually systemic from the start, which means that the cancer cells probably acquire very early the ability to go further than the pancreas and metastasize. It's also very hard to detect because the signs and symptoms are non-specific. And once they appear, it means that the disease is already advanced, either what we call locally advanced. So it's grown, it's starting to grow beyond the pancreas a little bit, or even to spread to further organs like the liver. Compared to other cancers in the past decades, there hasn't been a lot of research because unfortunately, patients didn't have any good treatments before, like good chemotherapy treatments, and they would pass away quickly. And so it was difficult to do research and try to have clinical trials to help improve outcomes. But we've been very fortunate that in recent years with improved chemotherapy treatments, that patients have been doing better. And there's been a lot of work also on the genetics of pancreatic cancer, and that has been opening up new avenues for treatment for certain patients. So in the general population, the risk of pancreatic cancer is very low, probably around 1.5 to 2%. And so it's not indicated to screen everybody because the risk is too low. And the challenge is to only screen the people who are at risk of having pancreatic cancer. And it's not very well known who is a high risk individual and how to follow them with surveillance to detect this cancer as early as possible. So there's two broad categories of high risk individuals at this point. It's people with what we call familial pancreatic cancer. So a family history of usually 2 or 3 close relatives with pancreatic cancer, or a genetic predisposition or a hereditary cancer risk. So being born with a change in a gene that usually protects us against cancer, that makes it so that the person has a higher lifetime risk of getting this disease. Um, there's no clear guidelines at this moment as to what is the best protocol. So we think that a combination of imaging and blood tests are the best way to do it now. So there's 2 different types of imaging. There's abdominal MRIs and endoscopic ultrasounds. And we at our center combine this with a blood test, and we look at 2 blood markers. One is the CA19-9, which is associated generally with pancreatic issues and pancreatic cancer. And the other one is a marker of prediabetes, which can be an early sign and symptom. And that's the hemoglobin A1C. There's thoughts, and one of the goals of PRECEDE is to see if there's any new biomarkers that could be used in combination with the markers we already have to try and be able to pick this up quickly. So there's a lot of partnerships and collaborations with other groups that are working on those improved detection systems. So the first step would be to contact us or ask their medical provider for a referral to our program. Then we can evaluate them to see what their risks are. If they're not eligible, if they only have one relative with pancreatic cancer, or for some genetic predispositions, the risk is low. So if they have a mutation in a hereditary pancreas cancer gene, but no family history, then they might not be eligible. But if they have a strong family history, or if they have a mutation, depending on the type, with or without a family history, then they could be eligible. So we will assess that to make sure they are. And then we see them in clinic to enroll them in the research, collect biosamples, and start the surveillance program. That's what we're hoping to do. So with a bigger cohort, one of the issues that we've had in the past is that these high-risk individuals are rare, and so it's hard to have a big cohort of patients that you can follow. And so the idea with PRECEDE is that by having all of those centers throughout the world, we can put all of our patient cohorts in common, and we can subdivide them better to be able to learn more about um, their own risk factors and how the surveillance might be best for each category of high risk individuals. So one of the ideas is to, I think we're about halfway through in our 10,000 patient enrollment goal. And so the goal is to really have more centers throughout the world at the moment so that we can reach this goal and have different cohorts to study. And hopefully the consortium will help elucidate which surveillance protocol might be best for all of those subcategories.